All right, guys, we're going to go ahead and get started here. My name is Chris Warrench. I'm a fourth-year medical student, and I'm the current president of the AMSSM Medical Student Interest Group. I want to start out by welcoming the students that came to this and go ahead and introduce our current student officers. We have Jessica Stambaugh, she's the vice president. Justine Falcon, she's the secretary, and our four at-large members are Kirsten Grudy, Sean Wynn, Shay Horton, and Jack Penner. I just wanted to take a second and encourage everyone to talk to their own school's sports medicine interest groups about recruiting members into the AMSSM so that everyone can participate in these webinars and, you know, get all the other benefits that you can have by being a member of this. If you want to talk about more about that, you can shoot me an email at any time or any of the other officers. And also I wanted to say as well that we'll be sending out an email soon looking for submissions for the Sideline report where you can write an article that will be featured in the group's newsletter. If you have any other questions during the talk, just type them in the sidebar and he'll address them. And then I think I'll turn it over to Jessica to go ahead and introduce Dr. Halstead.
Hello? Can you hear me?
Yep, you're good.
Perfect. Okay. Hi, guys. I'm Jessie. I'm the AMSSM VP here from UCSD. So thanks so much for listening in tonight. So we decided to focus this webinar on sports concussions since head injuries and athletes have been a hot topic lately. So we thought it'd be really important moving forward in sports med to be familiar with the identification and management of concussions. So with that said, we invited Dr. Mark Halstead from the Department of Peds and Ortho at WashU in St. Louis. So we invited him to speak to us given his position as the director of the Sports Concussion Clinic as well as team physician for the St. Louis Rams. Pretty cool. So he's also very involved in AMSSM on the board of directors. So Dr. Halstead, thank you so much for being here, and I'll turn it over to you.
Great. Can people hear me okay? I know you can't reply, but you can type it in if you can, just to make sure we're all on together. We good?
Yeah, you're good.
All right. So thanks for spending part of your Wednesday evening hearing about concussions. So this is a topic that I've spoken about quite a bit, and certainly a topic that's relevant. I know one that doesn't get covered very often in medical school. So hopefully going through what we talk about today, you'll feel a little bit more comfortable about concussions. We'll talk about some of the things that are maybe a little bit controversial, some of the things that are relevant just for general background, and then hopefully, just like I said, you'll leave this evening a little bit more comfortable going into residency, knowing about concussions. So I have nothing to disclose. So our goals tonight, we're going to talk about the epidemiology of sport-related concussions. We'll talk about in-office and a little bit on the field evaluation, although, again, we'll do this brief to cover everything that we can possibly think about concussions in an hour is hard to do. So we'll kind of glance over some things, but certainly try and make sure we touch the highlights of the important things. We'll talk a little bit about computerized neurocognitive assessment, because I think sometimes that gets a little bit so to speak, kind of too much play as far as its role in concussions, and we'll talk about its pros and cons, and then talk about return to play, and then just some other little side things along the way. So the thing about concussions, I think part of the problem, you know, having dealt with this when I was in your guys' shoes, when the current recommendations at that time were to actually, if someone was assessed and diagnosed with a concussion on the field, if that person's symptoms cleared up in 15 minutes, we were allowed to allow that person to go back to play. Now, obviously, we don't do that anymore, and I cringe of all the kids that I did let go back to play at that time. But again, that was the current guidelines, and that was no more than 15 years ago. So we're not talking ancient history from my standpoint. But I think, you know, there's too much negative that's about concussions right now. So I think the important thing is starting off with just some of the good news. And so the things I like to stress to patients, especially about this, is that most concussions, 85 to 90% of concussions, are going to be back to normal and feeling their normal self without symptoms within 2 to 3 weeks following the injury. So these do recover very quickly. You know, if you talk to professional athletes, they would rather trade their ACL tear for a concussion any day of the week, because obviously an ACL tear requires a surgery, and then they're going to be out for 6 months and possibly close to a year to feeling back to completely normal for their sport. So again, we put that a little bit in perspective here as far as the length of time here it takes to get better. I think we've sort of created this monster with concussions too, because we have this impression that these are things that are going to just drag on forever with horrible symptoms, but that's a rare case. So less than 5% of the patients we see, and some will even say 2.5%, depending on what study you look at, have symptoms that last beyond 4 to 6 weeks. And if we see patients that actually take longer than 4 to 6 weeks of getting better, we really need to be thinking about other coexisting injuries, and we'll talk briefly about some of those things later on in the talk. And really, I think the best management for a lot of this is just appropriate education in injury. There's so much misinformation out there on the internet that parents and athletes and coaches can readily access, which unfortunately creates a lot of conversations in the office that we have to dispel those myths. And then since it's been on the internet, Dr. Google is the expert. So sometimes that takes our word as far as going against, so to speak, Dr. Google. So the bad news, again, many misconceptions of concussions. That's what I deal with in my office on a regular basis, is way too many misperceptions of that. And unfortunately, a lot of providers are not equipped to provide the appropriate guidance and evaluation for concussions, not having the tools in their toolbox, so to speak. And then again, we've created this concussion crisis in the media, which further fears and misconceptions. I mean, back when I started, when I was fresh out of fellowship, I had a much harder time convincing families and athletes to stay out for a game rather than it is now, where I have a hard time convincing families that it is okay, even after one concussion, to allow their child to go back and participate in sports again. So again, we've kind of made this huge pendulum swing from not too much care about the injury into probably an excessive, inappropriate care about the injury on the other side of the spectrum. So let's just talk about a definition. So there's controversy even as far as how we describe the definition. So as you guys get further along in your training, you'll certainly hear more about the Concussion Symposia. The first one that was held in Vienna in 2001 when I was finishing up my residency basically came up with this definition for concussion. And this was just an expert panel that came up with this complex pathophysiological process affecting the brain induced by biomechanical forces. Now, I'd never tell that to a patient because that doesn't mean anything to them. That's a bunch of medical speak, but doesn't really kind of explain the injury. So the way I kind of describe it to patients is it's a functioning problem in the brain. It's not a structural injury, although probably on the micro level it is. But when we talk about kind of what really happens, the brain is not functioning appropriately, and that's where someone's getting their symptoms from. What they did in Vienna further is they put these 5 major features of concussions, which again, there's some controversy as far as whether all these things truly apply, but the first is it can be due to a direct blow to the face, head, or neck, which seems kind of obvious, or somewhere else on the body with an impulsive force to the head. I don't want to emphasize that one too much because they've actually looked at some biomechanics regarding a blow to the body that can produce the impulsive force to the head, and it actually would be a very, very significant blow to the body to really get enough whiplash-type injury to the head in order to create a concussion. So most of these are going to be from direct trauma to the head itself. There's a rapid onset, so typically within several hours of a short-lived, again, we're talking weeks or less, and oftentimes less than a week for the majority of patients, of an impairment of their neurologic function that resolves on its own. We don't really have to do much in order to get them better. However, again, there are some things that we'll talk about later that you may need to think about that are coexisting injuries with concussions that we need to help. Their acute symptoms are due to a functional disturbance. So again, kind of what I mentioned just a moment ago, it's a functioning problem in the brain rather than a structural injury. And that's where number 5 comes in. It's associated with normal neuroimaging studies. So when we get CAT scans and MRIs, the common imaging studies we have at our disposal, those are going to be normal. And so we can't rely on those tests in order to tell us if someone's had a concussion or not. There are some other advanced imaging techniques, functional MRIs and PET scans and things like that do show some of the disturbances that occur in the brain after a concussion, but those aren't readily accessible and oftentimes just done and used more in a research setting than actually in a clinical practice. And then it results in a graded set of clinical syndromes that may or may not involve loss of consciousness. And one of the misconceptions often about concussions is you have to have been knocked out in order to sustain a concussion. That's absolutely not the case. And the graded set of clinical syndromes is we kind of use the analogy to concussions of being like snowflakes. You'll never see the same one twice. And that's because everybody's going to behave a little different. Even in that person, their concussions can behave completely different from concussion to concussion. So we have to treat it as such rather than just having a cookie cutter approach to each of these. So just talking about how these typically occur. So in male sports, obviously football's the behemoth, but I think what doesn't get as much attention are the second and third place finishers here, which are hockey here, and let's see if that works, and then lacrosse here. The reason why these only have a couple bars is that when we look at some of these epidemiologic studies, these are more regional sports as it stands right now. So because of that, they don't get as much attention, but hockey's not that far behind football, but again, it just doesn't garner as much attention, part because obviously the NFL's a giant behemoth, and has certainly garnered a lot of the negative press about concussions, but we'll certainly see that happening in other sports too. You know, we see soccer down here. Probably soccer overall, if we just looked at number of overall concussions, probably gets close to these other top three here, just because of the fact that there's so many more people participating in soccer than those other sports worldwide. But again, in the big spectrum of things, the top three, which if you look in male sports, the interesting thing about each of these, helmet, helmet, helmet. So the three helmeted sports are the ones that we tend to see the most problems in. If we switch to female sports, since football's not really an option except unless you're in Texas and oftentimes the kicker, we really don't tend to see too many female football players, although they pop up here and there. But soccer obviously dominates, with lacrosse is just as equal as far as soccer goes. So we have to keep that in the conversation. And lacrosse is the fastest growing sport in the United States right now. The other thing to remember is cheerleaders. They don't get as much attention with regards to concussion, part because pretty much nationwide cheerleading is not recognized as being a sport. And because of that, they do not get all the services when you're at high schools and colleges of the athletic trainers, so there's not as much emphasis on that and the treatment to that, which also in turn means that the coaches don't typically get all the education like all the other sports do. And so that's unfortunately a downfall with cheerleading, so we have to remember that, because again, that we certainly see plenty of cheerleaders, and I generally see in my clinic it's a lot harder to convince a cheerleader and a cheerleading coach to keep their cheerleader out than it is the football player that they may be cheering for. And we certainly see that trend quite a bit. So if we look at percentages of that these occur as far as total injuries, so again, we see football over here, which interestingly enough, from a percentage of total injuries you'll get from that sport, the most common ones are ice hockey, boys and girls lacrosse, and then again, cheerleading. So we have to keep those in mind, that you're much more likely percentage-wise to get a concussion in these sports here of all the injuries that you can sustain compared to football. So it's not just you play football and automatically you're going to get a concussion. But the other thing to remember here, and this is what I stress with families too, is that if we use a 16-17% rate of your total injuries that occur in football, that means that 83 to 84% of the injuries that you're going to get in football are not concussions. So you're much more likely to get some other injury besides a concussion from playing football than you are a concussion. So we have to keep that in mind when we're talking about these with parents, because again, oftentimes they just assume they're in those sports, and so automatically you play football, you're going to get a concussion, but actually, like I said, you're much more likely to sustain an orthopedic injury than you will a concussion. So if we look at pathophysiology here, if we get down to the nitty-gritty of what really happens in the brain, so the neurons get disrupted. We start to see potassium leak out of the cell, which releases glutamate. When glutamate gets released, unfortunately, that makes more potassium come out of the cell. And then we wind up seeing other issues for increased demand for ATP and glucose, which creates this metabolic crisis in the brain. And so lactate accumulates and we get this decreased cerebral blood flow. And because of that, unfortunately, that's where we get this metabolic crisis, and again, the brain not functioning appropriately. This is all done off of animal models, and you're never going to get research approval and IRB approval to bonk patients over the head and then see what happens metabolically in their brain. Fortunately, with some imaging techniques, we may be able to determine that without having to do any fancy other techniques in order to determine this. But right now, our best bet right now is what happens in the animal model. So this is what we base what's really happening in the brain off of. I don't know what happened here. So if we look for common signs and symptoms, we can break these down into categories. So physical symptoms, cognitive symptoms, emotional symptoms, and sleep symptoms. These are the things that we're going to ask about someone when we talk to them about concussions. And so in the big picture of things, the thing to remember about this is that none of these signs and symptoms are specific for a concussion. So we have to take that into account when we're asking people about their histories. And when we talk to patients, we're going to certainly go through these at more detail and see if these are even things that may be pre-existing conditions for patients, because obviously someone who has attention deficit disorder, they're going to tell us that they have difficulty concentrating and potentially remembering, and that may be their baseline. It may have nothing to do with their injury at all. But again, these are the common things that we ask about related to a concussion. If we look at just kind of the statistics of things that occur from concussions, so headaches are the most dominant one, but the interesting thing to remember about this when you look at this graph is that headaches do not approach 100%. So just because you have a concussion does not mean that it's going to present with a headache. Odds are very high and very likely that that's going to be the case, but in the big picture of things, that doesn't mean that everybody's going to have one. Certainly we see dizziness as another common feature, difficulty concentrating, confusion, various visual changes, amnesia, and then again, loss of consciousness here at the end is a very small percentage here. So we're not typically going to see loss of consciousness except for probably less than 10% and oftentimes probably closer to 5%. So you have to remember that you don't need to have been knocked out in order to have had a concussion. So what do we want to do in the office? So we want to get a detailed information about what happened and when symptoms began. So did it happen immediately? Did they get symptoms that were delayed several hours after their injury? And that happens sometimes. So, you know, when you guys are watching football games or other sporting events and the ones that are nationally televised, and you hear the broadcasters, you know, getting all criticizing how the physicians are handling things on the sidelines. And if you ever get to that stage at some point, you'll understand the issues that go along there. If you evaluate someone, they may act perfectly fine after they've had what looked like probably was a concussion. They may pass all the tests that we do on the sidelines, and they completely feel fine. We have them exert, they feel totally normal. And then several hours later, meaning after the game, oftentimes, they start to develop their symptoms. So that's why we have to continue to serially evaluate these people during games to make sure that symptoms don't creep up, because they actually can later on down the road. So that's where, again, a lot of the criticism comes in is like, oh, that was so obvious, and they let that person go back into play. Well, they passed all the things that we needed to do. And so again, that's where you have to kind of, you can't be the armchair doctor and say, hey, oh, they're doing things wrong, because you, like I said, you're not the one evaluating them, and that happens more frequently than people realize. We want to consider using symptom checklists in the office, and I'll go through those briefly. You want to look at things that may modify their history, so that would be depression, attention deficit disorder, prior history of concussions, learning disabilities, and certainly going through an appropriate neurologic exam, looking for any focal findings that would suggest something more than a concussion is going on. This is an example of a symptom checklist, and on my screen this doesn't show up very well. I'm not sure what you guys see, but basically it's the graded symptom checklist that we use. And so the first column would be no symptoms, then we have mild, which they would grade as a 1 or a 2, moderate symptoms, and then severe, so it's a 0 to 6 point Likert scale. And we have a list of all those symptoms, so athletes would rate these as far as how they would feel. We come up with a score for that. There's not a lot of technically significance of the score, but I tend to use this in clinic as kind of a framework for myself as far as how I go through the interview with that patient. And I let them fill this out before they actually wind up we even have a conversation with them, so that way there's no preconceived notions of what exactly we're asking about. And because we know athletes like to withhold information and lie to us sometimes, because obviously their motive is to get back on the field as soon as possible. And if they circle zeros for all these and just put the big circle through it and say that that's all normal, well, again, those are the ones I actually worry about. So what do we do on the sideline? So there's various assessment tools that we have. We have what's called the Sideline Assessment of Concussion, or Standardized Assessment of Concussion, sorry. Symptom assessments, we can do the balance error scoring system. There's the Sport Concussion Assessment tool. There was version 2, now there's a version 3, and then there's a child version of it. I caution you on using the child version. That one really has not been heavily validated yet. So I'm not that convinced that we can apply everything that's on that to assess for a concussion. But the question is which one's the best one to use and what do the results mean? And that's a hard one, because a lot of these tools get put out because they're a combination of various assessments that people have studied previously, and then we try and put them together in one big assessment tool and say that hopefully we can determine that this person's had a concussion better. But there's no standards as far as saying, well, this person's had this much of a loss on their memory, and this person's had this much loss in their balance, and so that would signify a concussion. This is where having baseline assessments, meaning knowing how the player did before they actually had their concussion, and then using it afterwards, may be much more helpful than just trying to use these tools without knowing where that person was beforehand. So I'll give you an example of a study that was done on the SCAT2. So they looked at norms for high school athletes. And so as we'd expect, as you get further along, the SCAT-2 actually used a score, so it was a score out of 100. The SCAT-3 no longer uses a score, but they showed that 11th and 12th graders were better performing at this than the 9th graders, and that was statistically significant. So again, not unexpected. Athletes that had a self-reported history of concussions had lower scores than those with no histories, and again, it's a small percentage. They went down by just about 2 points overall on it. And then, as we typically see with a lot of these assessments, and bully to all you females out there, the females scored better than males, and that's typical for a lot of these assessments that we see. But the big thing that I think people should take away from this is we can't assume a baseline of 100 on that particular assessment as being a norm. And if we look further at the little scatter plot that they actually developed with this histogram here, you can clearly see this big, huge distribution here. You got a few people up here that are the super high achievers. You got a big, huge mass of people here in between 80 to 90. So again, we see kind of a cluster of people around here, but you've got even outliers way down in here in the 60s and 70s for an overall performance on that tool. So again, if you don't know that the person performs at this level and you do an assessment, you're like, oh my gosh, this person's horrible, but that may be their baseline. So this is where, again, having baseline assessments on these things can be to your advantage. But it's hard to do. It takes a lot of work to baseline do assessment on players for entire teams, and especially as you get to the younger kid levels where there's huge numbers of participants and probably very few people for resources to actually be able to do these and apply these. That's where it gets a little bit more tricky. It's a lot easier when you have multiple sports medicine staff members, and that's physicians, athletic trainers, physical therapists, what have you, that can do that at a collegiate level or professional level, but we just don't have that luxury. And sometimes you may just have one, if no athletic trainers at a high school. So, and then the high schools, you're talking about thousands of kids potentially in some of the bigger high schools, and that becomes a lot of work for someone to be able to do all that by themselves. And so again, we have to look at the infrastructure as far as how easy it is to do this on everybody. So what exactly is the BESS, the Balance Error Scoring System? So this is a postural assessment. Most use the modified version, which is the top group up through here. So these three up here. The bottom ones are done on a 10-centimeter piece of foam. Typically, that's done more in a clinical setting, but the sideline assessments actually use the top three. And so what happens is that there's three tests. So the first one, and these all take 20 seconds, the athlete will close their eyes. So they start with their feet together, hands on their hips, and then we watch for errors. And errors may be that they open their eyes. They may get movement of their hips more than 30 degrees off to one side or the other. They may take their hands off their hip. They may make a foot go backwards. So we're looking at errors, and they have in 20 seconds, they can get at most 10 errors for each of these assessments. So a total of 30 would be the worst you could do. 0 obviously would be the best score, meaning you got no errors in that 20 seconds. Then what we do is we ask the person, what leg would you kick a ball with? And that's the leg they pick up off the floor. So this person would be right-footed, so to speak. So they bring their right knee up. They keep their hands on their hips over here. And then we count them. This is probably the hardest one, and especially if someone's had a prior ankle injury as an example, or say they just really are poor with their balance, they may perform fairly poorly standing on one leg with eyes closed. And then the final one is a tandem stance. So we take their kicking leg, we put it in front of the non-kicking leg, so we go heel to toe, and then again, hands on the hips, like shown here, and again, we count for 20 seconds and we look for errors that occur. So there are things that affect this test. So if you test them after 15 minutes afterwards, their test may improve. Footwear can have a role into this. So obviously, if you're testing someone on the sidelines, typically for the Rams as an example, I baseline all my athletes on this in their cleats because I'm going to be assessing them in their cleats. We're not going to be taking off their shoes during the game in order to assess them for their balance. So we always test them in their cleats because, as you can assume, you probably would do poor on all of these assessments in cleats than you would barefoot. And then surfaces, so obviously that's where you want a comparison too. When we test these athletes for this, like again, the Rams as an example, I do this in the locker room. We don't do this out on the turf or the grass in front of national TV and seeing how they do. We do this in the locker room where it's quieter, and then, like I said, there's not a zillion eyes looking at them. And we're going to have a similar surface because I don't test them outside on the grass. I test them inside in the locker room. There are some rate or reliability issues with this test, and there is a practice effect, as most of these tests are. If you do it often enough, you'll get better at it and improve your score. So when should we send someone to the emergency department after they've had a concussion? So these are the things that make us worried something more than a concussion is going on. So first would be loss of consciousness, although the question is how long does that have to be? The general guideline has been 30 seconds of loss of consciousness, although, again, there's nothing magic about 29 seconds versus 30 seconds versus 31 seconds, and I can guarantee you no one is waiting for someone to get knocked out and standing by immediately with a stopwatch and clicking it in order to assess how long that someone's been knocked out. And if you've ever been in a situation where someone's lost consciousness and you're there, especially if you've got 60, 70, and in some college stadiums, 100+ thousand people watching you, 10 seconds seems like 10 hours when someone's been knocked out. So again, time perspective oftentimes gets lost a little bit. So if you've seen someone that's not coming around pretty quickly, it's probably worthwhile to send that person in. Any focal neurologic findings on their physical exam would be important because, again, that's suggesting something more structural going on. Progressively worsening mental status as you continue to evaluate them. Any sort of seizure activity, and again, seizure activity has not been shown to be correlated with intracranial findings. However, obviously seizures freak people out when they occur. So typically those are ones that wind up getting sent in, but rarely do you wind up finding anything significant from a post-traumatic seizure. Worsening headaches, so if they're continuing to get worse and worse and worse as time goes on, as you continue to observe them, that's a concern. And then repeated episodes of throwing up. And I've always had with my patients a 2-puke rule. So if they throw up more than twice, that's a guaranteed you got to go to the ER. Some people just after exercise or after a trauma, it's not unusual for them, especially if they get worked up about stuff, to throw up. I don't get concerned about one time, but certainly, again, if it happens repeatedly, that's something that you want to send them in for. And again, our concern now is structural injury that would require us to look at with further imaging, such as a CAT scan. So the neuroimaging, when are we going to do that? So all those things that I just mentioned as far as referral to the ER, those are things that I'm sending them in because I think they probably have something more going on, or they may have something more going on intracranially, and they probably need a scan. So CT scans are what we're going to typically order initially. It's not that common that we're going to get an acute MRI. That's much harder to do, and obviously what we're looking for is acute bleeds. And so in that acute setting, the CAT scan is going to be more than adequate. If they're having a prolonged recovery of severe symptoms, but they're not having any sort of red flags, that's also where we're going to consider imaging too. So an MRI if they're having a more prolonged recovery with severe symptoms. The big thing to remember, a CAT scan does not rule in or rule out a concussion, and certainly a normal CAT scan does not mean that that person had no concussion. We hear that all the time, unfortunately, is that, yeah, I got to the ER, I got a scan, they said everything was clear, so I didn't have a concussion, I just had some sort of head injury. Well, no. We expect their CAT scan to be completely normal when they have a concussion. If they have an abnormal CT scan, then that's going to be an issue. And so I saw the question, what did I say about the correlation of seizure activity? There's no correlation with seizure activity and intracranial findings. So when should we refer to a specialist? So someone like ourselves for the sports medicine people. So certainly anybody that's had prolonged symptoms, severe symptoms that aren't improving. I think that person's own individual comfort factor, and certainly patients with multiple concussions where we're starting to consider, is it appropriate for that person to retire? But the thing I stress, and we'll talk about this a little bit further on, is there's no magic number for concussions as far as when we would retire someone. I've retired people after one. I've retired people after dozens. And so again, there's no magic number that we use. Unfortunately, there's kind of this old wives' tale of 3 that's out there amongst families. I'm not sure where that ever came from, that you have 3 concussions and you can't go back to contact sport. There was a published concussion grading scale that suggested that if you had 3 concussions in a season, you should be held out of your sport for another season. But there's never been anything published in any literature ever that I've ever read or that I've ever talked to anybody about that automatically says that you have to retire after 3. So why can an athlete not be getting better? So these are the confounding factors that you have to think about in someone who's not recovering that typical 3-week time frame that we talked about. So depression. So think about what we oftentimes tell athletes after a concussion. Well, you shouldn't exercise, you shouldn't do this, you shouldn't do that. Well, we've taken away that athlete's identity. So they want to be exercising, they want to be involved with their team. We've taken that away. It's very quick for athletes to get depressed after that. Same thing happens with orthopedic injuries. They have a significant orthopedic injury, especially one that may keep a prolonged period of time out or require surgery. Athletes can get depressed. So we have to keep that in mind. And this is where sometimes your symptom scales come in handy, is you can actually assess and see these things going on, because we do assess for those type of emotional symptoms. And if you see an increase in their emotional symptoms, you certainly need to be asking that person more about that. Deficiencies in the vestibular system. So balance and our control with that oftentimes can be something that gets affected from a concussion. That may require some rehabilitation to get that person better. We're certainly seeing a lot more attention being paid to deficiencies in the ocular motor system. And so if they have something like that, that again may require some sort of visual rehab in order to get that person better. Disruptions in that person's sleep cycle. So sleep is important, but too much or too little sleep can have a negative effect. We all know how we've felt when we've had to be on call for prolonged periods of time. You're up all night. You can't function the next day. That's why all the guidelines have changed for residents and medical students as far as how long you can actually be in clinic or in the operating room or things like that after you've been on call, because it affects your judgment. So if you think about how you feel after call, you may have a headache, you may be out of it, you may not be able to focus well. Same sort of thing, if we add sleep disturbances on top of someone who's having a concussion and recovering from that, that can actually directly correlate with their symptoms, and it may not be the concussion anymore, it may be that they have just a really horrible sleep cycle now. Conversion of an undiagnosed migraine disorder. So some individuals do have underlying migraine problems, and they may have attributed that to the frequent sinus headache. That's one of the big red flags that I always hear is, oh, my kid usually, or as an athlete, I've always had sinus headaches. That's not that common for someone to have recurrent sinus problems. In fact, there was a good research study that showed that people that went to a headache clinic and they thoroughly evaluated these people for concussions with presumptive sinus headaches. Out of 100 people that came into that clinic with presumptive sinus headaches, only 3 of them actually truly had headaches that were attributable to sinus problems. And most of them were attributed to undiagnosed migraine problems. And then malingering, we really don't see that, at least I don't tend to see that very much in athletes, because there's really, I mean, they have a big, huge motive to get better, is they want to get back out on the field and play. So I don't tend to see that too much. I tend to see that more in athletes that may have had their concussion as a result of a bullying episode. So you need to think about that, especially the younger kids, if it happened from something like that, where they may not want to go back to school because they don't want to be put back into that environment. So you need to keep those things in mind. So what kind of neurocognitive testing is available? So again, several different types of things. So impact is probably the big behemoth that's out there, but there's Axon Sports, Concussion Vital Signs, ANAM, which is primarily a military assessment, although they have a sports medicine battery. HeadMinder no longer exists, and then formal pencil and paper testing with neuropsychologists. So what do these do? They give us some data of brain function, which everybody likes to put numbers on stuff because that way we can quantify our recovery. They've been used for many years with good normal values. Computerized tests are easy to administer, and it's much less time to do, usually a 20-minute or less assessment compared to formal pencil and paper testing, which can take several hours when we're doing a neuropsychological assessment on somebody. But things that can affect the test. And so these, unfortunately, you guys will find out in sports medicine, a lot of times in sports medicine, we like to put the cart well in front of the horse. We like to try new things because athletes want to try the cutting edge, and there may not be a lot of science behind it to support it. And then as time goes on, people start to do research in these things. And then just like a lot of other things in athletics, these fads go away, and then we don't see those things being used very much, or that was like, oh, that was an old school thing. So when these tests were being used, there are a lot of things that came out afterwards when people started doing research that actually can affect someone's performance on the test that has nothing to do with their concussion. So one of those being the environment that someone's tested in. So if we test someone in a group environment where there's a whole bunch of people clustered around a bunch of computers, whether we test them compared to someone who's doing it individually in a quiet clinic, obviously the people that are doing their test in a quiet clinic are going to do much better than in the group. There's practice effects. So if you have someone take it multiple times, that certainly can affect their performance. People that are very good and savvy at computer use can do better at these tests. Sleep has been shown over the last several years on several studies to show that actually you perform much worse on these tests if you get too little sleep, as we would expect, and actually also decrements when there's too much sleep. If someone has a baseline level of depression, that can cause problems, your overall effort on the test, and then certainly as someone gets older, we'll see their baselines change, although it's felt that these scores on these tests are stable after the 10th grade. So what role do they have? I think they could be part of a comprehensive concussion evaluation program. We can't just use these individually. They may help identify that not so forthcoming athlete. So when someone who circles the all zeros, like I mentioned before, on a symptom assessment, that's someone that I'd be concerned about. These may offer some additional information for us. But if we really want more concrete and specific neurocognitive evaluation, we need to think about formal neuropsych testing, which, again, it doesn't tend to happen or doesn't need to be done very often, but certainly something to consider in someone, especially if they're having a prolonged recovery. So what they don't do, they do not predict our length of recovery for someone. They do not provide prognosis for future problems for that person. They never should act as the sole determining factor for return to play. So we can't just make return to play only on their performance on the test, and they do not act as a red light, green light. So it's not like you didn't return to your baseline when you did a post-injury test, and we can't let you go back to play, and vice versa. You've reached your baseline, but you're still having horrible symptoms. That doesn't mean that that person gets to go back to play in that situation either. So we have to use these, again, as one tool in our toolbox, going back to that toolbox reference from at the start of the talk. So this is just one research study that I just pulled up on computerized testing. This is looking at individual baseline testing. So this looked at high school athletes that were tested on impact in a school computer lab, and then they also compared it to high school athletes that were done individually in a neuropsych clinic. And as we can see, all the performance scores were much higher in those that actually were tested in the neuropsych clinic. So they did much better than any of those that were tested in the group setting. And that actually also held true when we excluded the athletes with histories of concussions or attention deficit disorder or learning disabilities. And then when we looked at invalid tests, so that these tests typically have built-in parameters to them to help us determine if someone's really given a good effort or not, much more invalid tests in the group setting than in the individual setting. So, only 0.3% compared to 8.5%. So again, this is an example of group settings that are probably not ideal. So having all these kids basically piled up, and you got all the girls on one side, all the guys on one side, probably not that great, because guys are probably looking at the girls over here and then they're distracted from their tests, so probably not our ideal thing. And again, looking at this environment here, the laptops can be a problem if they don't have a mouse, because the laptop trackpads, if you use those, it doesn't actually perform on the test very well. So you have to make sure they use a mouse. And again, this is a situation where they're all piled up here, and that's probably not our best situation. This is one other example. So Dick's Sporting Goods actually had a promotion where they were offering a free year of baseline assessments to high schools that signed up for this, and even Dick's Sporting Goods was doing testing in their stores. And this is a picture, an example of that, so that they basically just put up these walls around there, and they have these people on their computer screens, and the store's open, so you got maybe people up here looking at them. I'm sure you got a noisy store at times, and they're trying to do a computerized test. That's probably not going to be the most effective score for those athletes. So nice effort that they wanted to do this and help this out and provide it for free. The problem is again, you have to have a good testing environment to do that as well. So let's talk about the concept of brain rest, because I think this gets mislabeled a little bit too of what we mean. So initially what we need to do is we need to restrict that person from physical activity that increases their heart rate or blood pressure. So that could be gym or recess for younger kids, any sort of sporting activities, working out, any sort of recreational activities that may get their heart rate up. And again, those restrictions can change based on their improvement of symptoms. So it doesn't have to be until that person is totally symptom-free, we can't let them do activity. In fact, actually, there's some good evidence that actually if we start letting people do some activity as their symptoms start to improve, that actually may help their recovery rather than hurt them. So we don't want to just wait necessarily until someone is completely symptom-free before we start some level of physical activity. Now, again, it won't be returning them to sports if they're still having symptoms, but maybe some light cardio for 15 minutes just to let them start doing something. And then again, we talk about reducing cognitive stress. So this is where sometimes the school part of this for the kids that we see in high school, college, and younger, this kind of gets taken to a wrong perspective. So it's not that we have to keep these kids out of school and make them do nothing. I joke with my patients in clinic that the only way we really will make our brain rest and not do any activity is you're dead. And so obviously we're not doing that to get someone better after a concussion. And there's actually good research that I'll show you in a second that actually if we just reduce their cognitive stress and just back off some, they get better just as quickly as if we don't. We may need to limit things like video games, texting, reading, and computer use. I think this, unfortunately, to me is the biggest bane of my existence, is these recommendations that came out saying that these have to be eliminated. If you think about texting as an example, texting is probably not the most cognitive stress that you can do in your life, yet we say it's horrible after a concussion. Same thing with TV, as we tell athletes all the time, or patients, you shouldn't be in front of a TV, yet we talk about how TV really does not provide any meaningful cognitive stimulation to us. So which one is it? It's either it's cognitively stressful or it's not, and I would say it's probably the latter. So again, I will limit those things to some extent, but actually electronics can actually be to our advantage in some of these patients as they recover, because I can actually adjust font sizes. So if someone's having an ocular motor issue and they're having a hard time reading small text, I can increase the font size to the grandma, grandpa size font, so that way they can actually not put as much strain on their eyes, and that can help. I can use those electronic devices to provide audiobooks as an example. I can actually adjust the brightness on monitors if they're having troubles with sensitivity to light. So we can do a lot of things with electronics that we can't do with our normal other things that we use every day, like just books as an example. And then we want to consider restrictions on driving because reaction time after a concussion is an issue. I will use at least for the first several days after a concussion and sometimes up to a week, just depending on how that person's recovery. And certainly if they're having a hard time focusing and concentrating and having lots of symptoms, especially if it's a younger driver, I don't want to have that person behind the wheel because already they have enough distractions with their phones and being new drivers that's probably not the ideal situation for them. So let's talk about a little bit about return to learn. That's one of my big areas of interest just because I helped write the statement for that for the American Academy of Pediatrics of guiding returning to learning after a concussion. So this is a study that was done that looked at activity intensity, symptoms, and performance on the neurocognitive testing, the impact test that we referred to before. And so what they did is they rated activity, and so level 0 was no school or exercise, and then we increased it to level 4, which is they're doing school activity and participation in sporting games. And what they showed is that actually when we look at the various components of the testing that gets done on impact, the athletes that scored the best on the test were the athletes that were doing some level of activity and back in school. So kind of what I mentioned before, there's actually some benefit actually there to doing that. People that were at the highest level of activity didn't do very well, and people at the lowest level of activity didn't do very well. So there probably is some sweet spot of the activity that we need to search for in order to get these athletes better, but that's challenging because that, again, each of these individuals are really unique as far as how we deal with them. So it's going to be harder to say exactly, the time course that we do. But again, this is where talking with your patients and following their recovery will help you as far as when's the most comfortable time to let that person start doing stuff. But we don't want to keep them out of physical exertion for a very, very prolonged period of time because that also can have some negative effects. So also this is another study that looked at following a lot of athletes prospectively, most of them male, a high percentage that had loss of consciousness, and so when they came into clinic within 3 weeks of their injury. And they also looked at various types of things as far as rest from cognitive activity. So complete cognitive rest, which was a level 0, to significant cognitive activity, which basically means they were doing all their normal things. And so if we look at the recovery curve as far as how these athletes got better, I think the big thing to notice here is this one here. So this recovery curve is the athletes that did not make any changes at all in their cognitive activity. They took the longest to get better. If we look at this cluster here, very similar recovery curve. This is basically anybody who backed off, say about 20 to 25% of their activity to those that did complete rest. So it doesn't take a complete rest in order to get better. We just have to back off some. So we're not doing that full level of exertion. And the hardest athletes I find this to be in are the highest achieving students. So probably what all of you guys were in school. Those are the ones that have the hardest time giving in, the hardest time asking for help, the hardest time backing off even just a little bit as far as their cognitive activity. But if they just back off a little bit and let the teachers help them, and they can get a lot better a lot quicker. So, and this is another study looking at is strict rest better. So this was just published this year. It looked at athletes that were sent back to school within a day or two compared to those that were kept out of all school, work, and physical activity for 5 days. And then when they recovered, they let them go back to a normal return to activity progression. And so this was looking at their symptom scores. The usual is the white bars here, and then the strict rest is the darker colored bars. And what you can see here is that actually there was a statistically significant change as days went on as far as the symptoms. And those athletes that were back in the school environment, actually their symptoms improved sooner and at a better rate than those that actually were kept out for a longer period of time. So there is benefit actually, like I said, to getting these kids back to school rather than keeping them out for a prolonged period of time. And then this looked at basically how well they did their rest, and so this is looking at their compliance basically. And so again, we talked about the white bars are the ones that were let to go back to school, so we can see their level of activity was higher, and then the ones that were resting, they were all lower, but again, they did comply for the most part, but as you can imagine, by the 4th or 5th day, they get a little antsy with that, they get bored, and then we can see at the day 6, they're basically at similar rates here again. So again, there was pretty good compliance with the treatment protocol here. And again, this just shows that with strict rest, the recovery curve is longer compared to those that actually did the usual care and got back to within 1 or 2 days. So this is, again, where we try and get kids back into the school environment sooner rather than later. Again, when we talk about doing too much mental activity, if you think about it this way, if someone's at school and at least getting some of the education and getting taught on that, even though they may not be comprehending everything, and say they're just getting homework sent home instead because they're staying home, which one do you guys think is a lot harder to basically try and do for homework? Is it the one who's been in school and gotten a little bit of that teaching versus the one who's trying to do it all independently? And I would say it's the latter, who's having to try and do it all by themselves. That's certainly going to be a lot more cognitively stressful than being in school. So let's talk briefly about grading scales. So there's a lot of misconceptions about this. Please never ever use the terms grade 1, grade 2, grade 3 for concussions. These have been recommended to be abandoned since 2001. So for the last 14 years, we shouldn't use it. I cringe every time I still see concussions getting graded or talked about in terms of grade scales in the media. In fact, actually the Packers athlete, I think it was, just this past week talked about him being a ticking time bomb if he went back and was told that he had a grade 3 severe concussion. And again, we don't use that anymore. And I'm not sure where he got that from, because I know the people who take care of him in Green Bay and Mike McRae, who's the neuropsychologist who deals with that, I know he would definitely not be giving those recommendations. But there's at least 30 different published grading scales on concussions and mild traumatic brain injury. They're not all sports related. None of them are evidence-based. They're basically, I could create the Halstead grading scale and put some guidelines and parameters in there and give some recommendations as far as when someone could go back to play. And those were used for a long time, but they never predicted our clinical outcome. They were based on typically very few symptoms, usually loss of consciousness and amnesia. And so again, those were recommended to be abandoned from use. And so we just tell that someone has either been concussed or not. I also would discourage you from describing to patients that they've had a mild concussion or a severe concussion. When you use those descriptive terms on there, that actually makes that particular athlete or that parent have very different connotations as far as what their expected outcome is going to be. So again, just use the term that they had a concussion. Don't start putting labels in front of them, because again, putting mild in front of it oftentimes downplays it, and then the severity of it isn't really kind of put into the perspective that it had been a brain injury. And then severe, like I said, that oftentimes makes huge implications as far as what our expected outcome is after the severe injury. So when do we let someone return to play? So typically they need to be back to their normal self at rest. And again, this is where your symptom checklists come in. That doesn't mean that someone has to score a 0, because like I mentioned before, people do have a baseline level of symptoms, and so we have to account for those. So if they're back to feeling their normal self, their pre-injury status, that would be considered to be back to normal. We have gradual increases in their physical exertion. They have no return to their symptoms with the exertion. They're back at their pre-injury level in school, and then they've been off of any medications that were used to control their acute symptoms. And then again, we have to account for any pre-existing problems that that person may have. So this is how we go through a return to play progression. It's typically a 5-step approach. It's got 6 on here, but the 1 is basically the rest to start off with, so we can basically eliminate that. So step 1, when they're feeling back to their normal selves, so we would have them start doing some light aerobic exercise, and the goal of that is to just increase the heart rate. Step 2 would be a sport-specific exercise, which is where we're adding movement into this, and so we're adding, again, an additional stress. Step 3 would be doing non-contact training drills for that particular sport. So again, we're doing some exercise, we're adding some coordination and cognitive load at the same time. And then the final step would be letting them go back to a full practice. We don't have to use the word contact in there, because obviously not every sport has contact for practice. But as long as they've gone through a full normal practice, again, getting back their confidence and looking at their functional skills, and if they've gotten through that, again, symptom-free, without any worsening of anything, then they're allowed to return to games. So typically it's a 5-day progression to get back to gameplay. So really, if we're talking about a football player who gets a concussion, if they're really not back to their normal selves within a couple days, they're probably in all likelihood going to miss that next game. So what about retirement? So how many is too many? Like I mentioned earlier, there's no magic number, and it's really unknown as far as how many is too many. Is it one hit that causes problems? Is it multiple hits? Again, we really don't know that, and there's no really standard agreed criteria as far as what do we use as the ultimate criteria to recommend retirement. And if you put a bunch of people who deal with concussions in a room, you'll get all sorts of different perspectives as far as when and comfort level that someone should be retired. Again, this should be individualized, and I look at multiple factors. I look at the sport that they play, the position they play in their sport, how many they've had, how severe their symptoms were, how much it affected their life after that concussion, and then certainly what their ultimate goals are. So a kid that's just playing recreationally that's had multiple concussions versus a kid that's basically a really high-level athlete that may be at professional kind of status. Again, we may make recommendations differently for each of those individuals as far as when they should stop doing stuff. And again, the question is do they need to be excluded from all sports? And certainly I would say no, because there's many sports that are out there that have very little to no risk of concussion. So certainly we can still keep that person active. And again, as a sports medicine provider, that's what our goal is to keep people active. So again, these are the things I just mentioned. So the number that they've had, duration of symptoms, the injury that they affect on their life, the sports that they play, the positions they play in that sport, their style of play, which is a really important one. So the very aggressive athlete that does everything at all costs, that's the one that plays with reckless abandon. Those are the ones that are going to put themselves at higher risk for concussion. And again, as I mentioned, long-term goals for that athlete. Let's talk briefly about CTE, because this, again, brings a lot of controversy, and again, you'll get various opinions as far as how much of an issue this is. But basically what chronic traumatic encephalopathy is, it's findings that were discovered in athletes at autopsy, although this has been talked about for many years prior to the big influx over the last several years with NFL athletes. Basically, the problem is deposition of the tau protein in your brain. The question is it a direct effect of head injuries? I would say yes, it is. But the question is what does that finding mean clinically? And that's because they have actually found brains who never, and they found this tau protein that never had any clinical manifestations of any problems. And we don't really know if there's a correlate with the amount of tau that gets deposited in the brain, and what does that mean for that person's clinical findings. And so that's the hard part, because again, we're seeing these people after autopsy. The thing you also have to remember is that there's a huge bias with all these that are being done, because generally these brains are being assessed on athletes that have had problems. They've committed suicide. They've had parent or family members who've been concerned about mental health issues that athlete may have already had. And if you think about it in the big spectrum of the millions of athletes that have been out there, we have, I think right now, there's probably about 100 brains that they've looked at that have found this, and again, many that they have not as well. So the problem is we don't know the bottom denominator of really what the prevalence of this is, and it's created this monster too with this particular problem as far as how significant this is. I don't want to downplay CTE by any means, but again, we really need to have better science as far as saying really what is the bottom denominator as far as what's the likelihood of this developing, and then what does it mean clinically for that athlete, and we just don't know that. So let's talk about prevention a little bit, because I think that's important. So mouth guards have really never been shown to increase or to decrease concussion incidents. Your dentist will love you for having your athletes wear the mouth guards, because we certainly see lots of dental trauma. I encourage you, if you can, when you're doing your training, if you're going to go into sports medicine, is find a good sports dentist and work with them a little bit, because it's very interesting, some of the dental things. And I've been amazed at probably every single basketball tournament I've ever covered. There's always been, the major problems have always been the dental injuries. And so knowing what to do for dental emergencies, I think, is helpful. Helmets, again, I think this is where we're maybe barking up the wrong tree. It'd be great to develop a helmet that would protect against concussion, but the thing to think about that is I'm just putting more and more external protection. However, we're still letting the brain move in the skull, and I think that's the problem, is if we can create some sort of helmet that helps reduce the rotational component of things, that may actually help quite a bit. They have developed a bike helmet actually in Europe that's designed to help rotate basically as someone gets that shearing force when they hit the ground. The question is can we actually apply that and make that work in a football helmet as an example? And I don't know if that's possible or not, but that may be helpful as far as reducing it. But if we're hoping and placing all of our bets on the helmet, that's probably not going to be our best answer. How about headgear in general? So obviously a hard helmet's not going to protect, so a band of air around the head is probably not going to do that either. I see certainly lots of soccer players who are wearing these. I tell all the families when they ask about it, I would not put my kid in a headband if they were playing competitive soccer. It's shown that proper heading has never been shown to be a significant source of concussion. However, inappropriate heading is, and so if someone's not basically had their neck stable and they're intentionally heading the ball, that does increase your risk for a concussion. Same thing as if you're going up for a head ball and two people collide because they're not paying attention. That's how concussions occur from heading from that particular method. And so really probably our best prevention, I don't have a slide for this, is probably neck strengthening, and there actually is some research to support this. So if you think about the concept of we got this big bobbling thing around a small little stalk, if we can actually strengthen the neck muscles when we get hit, if those neck muscles are prepared to stabilize the head, that probably can actually reduce things more so than the external force. And there actually was some research to suggest that for every additional pound of strength that you gain in your neck, that can reduce your concussion risk by 5%. So I tend to tell my families if they really want to do prevention techniques or reduction techniques is get your athlete on a good cervical strengthening program. And then I leave this up here because I always like to have some little entertaining slide. So Peyton Manning, I'll have to pick on him a little bit because he wasn't our ideal role model. I mean, obviously he's pictured as a big role model. He's a very likable character. But this is a quote that he had in USA Today and back in April of 2011. They have these new brain tests that we have to take before the season. You have to look at 20 pictures, turn the paper over, then try to draw those 20 pictures, and then they do it with words too. 20 words, you flip it over and try to write those 20 words. Then after a concussion, you take the same test, and if you do worse than you did on the first test, you can't play. So I just tried to do badly on the first test. So obviously that's not our ideal message that we want to give to athletes. Fortunately, this did not get a lot of attention in the media, even though it was in USA Today. But again, Peyton's got to watch out what he says. And clearly, obviously, if this is what he practices, that's not good practice for him as well. And so I'll end there. And so that was kind of a whirlwind of concussions. And so certainly if you have some questions, feel free to type them in. I'm happy to answer them. And I certainly appreciate you guys spending some time tonight. And there's my email. If you have any other questions you want to ask me offline, I'm more than happy to answer them. So feel free to type away.
Thank you, Dr. Halstead. So yeah, if anyone has any questions, just type them in the sidebar and I'll feel free to read them to them.
Yeah, okay, so the question is, what do I tell athletes and families about sleep after the concussion? So that's a good one. So there's lots of misconceptions about that. Again, the old wives' tale that you need to wake someone up every few hours. We're not seeing athletes die in the middle of the night because of their concussion. I stress with every single family member, if I've looked at that person, we've looked at them, we've been able to observe them for a few hours, they're not getting worse, let that athlete sleep. They're going to do much better getting a good night's sleep after their concussion than trying to wake that person up. And if we think about teenagers or even just going back to college, trying to wake someone up every couple hours as a teenager and trying to assess how they're doing, I mean, that's ridiculous. I mean, unless you're medically trained and you know what you're looking for in that person, all you're doing is just disrupting that person's sleep. You're not getting a good night's sleep either. So again, my big stress that I talk with all families is just everybody get a good night's sleep. Again, if something bad is going to happen, meaning that they're developing bleeding in their brain, and one of those slow subdurals as an example, we're going to start to know that because their headache's going to progress. They're going to start having vomiting typically. Those types of things are going to come out. That person's not going to just die quietly in the night if they have a severe head injury like that. So like I said, everybody get a good night's sleep, and that's really the best advice for that athlete rather than trying to get woken up. Any other stuff out there? You're welcome.
All right, it looks like that's all the questions. So we greatly appreciate you doing this, Dr. Halstead. Jessica, do you have anything else to add?
Yeah, thank you so much again. If you guys have any other questions or recommendations for future webinars, feel free to shoot us an email. It can be found on the AMSSM student page. That's also where you'll be able to access the recording there in the next few days. So if you want to refer back or share with your sportsman interest group members, you can find it there. And yeah, if there's no more questions, study hard, guys, and good luck in your fantasy football leagues, and we'll see you at the next webinar. Thanks, everybody.